Hello and welcome on behalf of Mark Fox and myself, John Pandolfino. It's my pleasure to introduce you to the Chicago Classification 4.0 panel discussion and questions. We've obviously gone through the videos and now we're set to answer some questions. And I'm going to hand this off to my colleague, Professor Mark Fox.
Well, thank you very much, John. Thank you, and also to Rena, for bringing this process together. It was a big job bringing such a diverse group of people together and still maintaining consensus most of the time. And obviously, what we're planning to do today is to work our way through the various presentations and to allow members of the faculty here who've joined us, thanks to all of you as well, to ask questions and respond to any issues that arise. So just to be clear, the faculty here is not limited to answering questions specifically about their presentation. If you want to riff on other issues and bring in other things for discussion, then one is free to do so. We're hoping to make this as real life as possible. With that in mind, it is my pleasure to introduce John Pandolfino, who's the Hans Popper Professor of Medicine at Chicago Northwestern. And John, you've obviously been involved, as I have, and several people here, since the very beginning of the Chicago process. What has been for you the most important advance here in Chicago 4? And is there anything you regret, on the other hand?
That's a great question. I think the strengths are really the fact that we tried to correct some of the mistakes, I think, that were made in the previous iterations. And when I say mistakes, I think I'm more inclined to look at them as kind of oversight. What we tried to do in this particular iteration was really focus on giving people the opportunity to make a conclusive diagnosis. We really sought to bring in complementary tests, whether those were provocative swallows, pharmacologic interventions, or potentially other types of tests like a sonogram and the functional lumen imaging probe. And that to me was really the benefit here, was that we were able to bring that in so that people could be more confident and they didn't make mistakes, because we were seeing people getting sent for interventions with kind of inconclusive diagnoses that were basically manometric patterns as opposed to true disease states. In terms of regrets, I think I would have liked to see impedance in this version, but we probably weren't there that we could really push impedance into 4.0, and maybe it'll make it into 5.0. And I still think we need to do a lot of work on jackhammer hypercontractile disorders and spasm. I think there's a lot of stuff we don't know. So that would be what I'd say are the strengths and some of my regrets.
And so as it stands at the moment, maybe I'll direct this to you, Rena. Do you think what you've produced here is truly an evidence-based classification, or do you think this is still very much sort of expert opinion with some sort of input from the scientific side?
Sure, thank you, Mark. That's a great question. And actually, part of the priority of Chicago classification in version 4.0 was really to be as evidence-based as possible and move away from any sense that this is purely expert-based or based on a small group of individuals. So, speaking to that, Chicago classification 4.0 included 52 individuals from across the world. So really a very large and diverse group. And in order to make recommendations with such a large group, we were able to facilitate it by using two formal methodologies. So one was the formal validated RAND appropriateness method, which is really important to keep in mind that this is a method to identify where a large group of experts agree that there is a strong recommendation, but it is not meant to develop consensus. And actually, there were many areas where the group did not agree on, and those did not make their way to Chicago classification. And then another important point is that we utilize the grade method, which is really the best method we have right now to assess the quality of evidence and incorporate it into recommendations. Now, in areas where there wasn't as strong or sufficient data, we did look to the experts and collectively utilize their recommendations. But I would say that this is as evidence-based as it can be.
So we've included a lot of provocative tests in Chicago 4, and we've, as John has mentioned, included indeed other investigations, or at least we've referred to them. Is that there wasn't always really consensus for all of these things, but we've chosen to be as inclusive as we can. Tell me, so do you think that was the right thing to do? Do you think it's right that we've given people so much flexibility, for example, starting in the supine or starting in the upright position? Do you think there's disadvantages to any of that, or do you think that's a strength?
Well, I would say it's a strength. I think the previous iteration may have been a little bit too restrictive. And I think this does give people a little bit more flexibility to interrogate the patient like you would do in real life. And I think this is, where if you only get 10 swallows, you don't know the answer, you just don't stop. You have to do other things. And I think it's a little bit more generalizable to what people do in clinical practice. So that I think is a strength. I do know that there was a lot of debate on that particular issue throughout the process. But in the end, I think we put together something that the majority of people felt very comfortable.
So Irena, it's a living document. You've come to this slightly more recently, but hopefully you'll be here for a long time to come. As a living and breathing thing, in what way do you hope this is going to develop and grow as we look towards version 5 in, I don't know, hopefully less than 5 or 6 years?
Absolutely. When you go through an initiative and a process like the Chicago classification, of course, the final product is important, but I would say equally as important is understanding where there are gaps that we need to address to move forward. And so certainly this is an iterative, evolving process. I think John touched on a few of the areas that we had really hoped we would be able to provide more clarity on, such as spastic esophageal diseases, really understanding different phenotypes of them and which ones equate to clinical pathology, which ones might be more manometric patterns in response to things such as reflux, and then also incorporating impedance. And we have so many novel ways to assess impedance on manometry. And so hopefully both of those will play a role. And also now in 2021, the new research methods that are being applied across the field. So machine learning, artificial intelligence. I'll be very interested to see how they make their way into the next iteration in 5.0.
Well, thank you very much, John. Thank you, Irena. I'm going to now move back to John to ask questions from the next section, which of course involves myself. Don't forget, if you raise your hand, then the person who's guiding the discussion will know to bring you into the conversation. John.
Yeah, so building on what we just discussed in terms of some of the changes, I mean, obviously, the protocol was something that required a lot of effort and debate. And two of the people who spearheaded that were obviously Mark Fox and Natalie Rommel. And for this particular section, we really want to focus on those particular aspects, because as we mentioned, there was a spirited debate in terms of that. And Natalie, I'll start with you. Were there any things that you remember during the discussions that didn't lead to consensus that you felt might have fallen short of what we were trying to accomplish?
I think I was actually quite happy with what was reached, that we changed, that the option came in of changing the position of the patient, and that the option was created to include, if you were still looking for a conclusive diagnosis, that you had the option to include solid boluses, for example. So I think in the end, after the whole process, I think I was happy with what could be included, although it wasn't forced on everyone. That is my opinion. And I, in some ways, yeah, as you said, I kind of regretted that the impedance was not included in there, because I think it could have added some value. But the way that the protocol was set up now, I think allows to include many people who already have very much experience in their clinical practice, and it allows that flexibility. And I think that is one of the biggest strengths of this new protocol. I think
Right.
that is crucial. Yeah.
Well, certainly, I think there was a spirited debate, and I think being part of the Chicago classification, you definitely have to have thick skin, because as soon as it gets published, everybody's a critic, and there's always going to be people who have some comments. And I think I'll direct this one to Mark. I think one of the things that we've heard over and over now is that we've made Chicago classification too complex. It's complicated now with this new protocol. How do you answer that question, or how do you answer that?
There is a degree of complexity. I think the real concern that I have is that people don't try to overthink this in a sense. The water swallows still provide the basis. They provide a guide, and yet they don't always provide the answers we're looking for. And so the way I try to encourage people to use the consensus protocol that we've developed is that you should, as you've mentioned yourself, just continue until you are increasingly certain that you've reached the diagnosis that you need, and that you are answering the questions that you've posed. So if you're interested only in excluding achalasia, as you might be if you're doing a straightforward reflux patient workup before fundoplication, then you may not need to do a great deal of the protocol. On the other hand, if you're really very concerned about trying to find out what the causes of symptoms are in a patient with quite a complex history, maybe post-operative, well, that's another issue to address, or that has been through many investigations before, often multiple times, then really you may well want to go through the whole thing and include the optional test meal at the end to really see how they eat, what happens when and even after they're eating. So that is our ambition in developing the protocol in the way it is. And we do provide quite clear guidance in the recent technical note that we've published in Neurogastroenterology Motility to try and help people select in each particular situation that you may find yourself the appropriate provocative tests so that one can get the best out of this process. Now, I note we appear to have lost John. Never mind. But let me direct a question to you, Natalie. So you regret, understandably, because you've done a lot of work here, you regret that impedance is not there. Mm-hmm. What do you think it really adds? What are the killer apps that the impedance will give you that we don't get just using manometry?
Well, I think its strength lies in the fact the way it can measure the distension pressure and how it can tell you something and how it can detect these obstructive processes where your HRM is normal. And I think that is, to me, a very valuable point within the same measurement. I think this is a very valuable point. It helps us to understand also how the response of the contraction is versus this distension. And that tells us beautifully in how it links to symptoms. And I think this is one of the most important things, that with what we see in the impedance, it corresponds to what we see and what we hear from the patients that are the symptoms. So I think that is very important, and it confirms your outflow, EGJ outflow problem. And I think within the same measurement, and that is, I think, one of the most important things that I found that is there, and it's not that difficult to understand and to use. If that is what I regret, that hasn't happened. But look, we have to continue to see how things will evolve, and hopefully we will be able to make it accessible to everyone, that you can see what we mean.
And can you use it with solids as well?
Yeah, you can use it with solid, with viscous bolus. That it tracks even better with a viscous bolus and with a solid bolus. And here in this, I would also like to add, which relates to the answers that you gave in the previous question. People are very concerned about the length of the protocol and is it tolerable for the patient? I mean, we've been doing this with liquid semi-solids since for a long time, and patients do tolerate this really well. The time, even the longer assessments, they do tolerate really well. It links to their normal physiological process when they eat. And if that is a concern to some people, I can assure you that once you're used to this multiple testing, people, do it, and also the nursing staff and physiological staff, they do it in a very fluent, natural way. It's just a change. Is that an answer to your question?
You've reappeared from the ether. Do you have any final questions, maybe, for the protocol?
Yeah, I think, what Natalie brought up in terms of the complexity and how onerous this process is, I think, is a very important point. And Mark, you although you have brought in these provocative swallows, you have been a big proponent of just starting with the upright swallows and moving on from there in that sequential way. Can you speak to that a little bit?
Well, I mean, to be perfectly frank, I think that the supine swallows are just simply a throwback to a period before high-resolution manometry and solid-state sensors became available. When in the bad old days, when we just had maybe 3 or 4 sensors and water perfused and microtransducers, and we needed to correct for hydrostatic pressure artifacts, or not artifacts, effects, then of course it's very understandable why the supine position was preferred to the upright position. It was easier to acquire and interpret the information. But now I completely accept that the swallow sometimes looks better in the supine position, particularly if we are talking about water swallows. But that's not all that critical from a clinical or scientific basis, when of course it is in the upright position that people eat and drink normally. And the effect of gravity is actually quite important for bolus transport in certain situations, especially when peristalsis is very poor and when there may be an obstruction present. So I do generally do my routine clinical work upright only. But for the research, we use the full protocol, of course. And I don't know how many people will follow this lead. I have like Natalie was saying, comfort is important, and changing position with a catheter in your nose is actually one of those moments when it can be slightly irritating. But I know that I'm an outlier here, and I wouldn't want to insist, which is why we've made this inclusive.
Well, that's as Reina said, this wasn't meant to build full consensus and have everybody agree 100%. And I think, we all respect each other. And I think that was another great thing about the process, is that people were always very respectful of other people's opinions and understood the pros and cons of everybody's approach. So I guess we're at that time where we need to shift gears probably to one of the most controversial topics at the Chicago classification, which was the EGJ outflow obstruction. So I'll pass this along to Mark now.
So yes, indeed. So turning to Arjan and to Dustin. Arjan, in your talk, you suggested that achalasia is a heterogeneous disease. How do you see that at the moment? Do you think the current division of types, and indeed the division between achalasia and EGJ outlet obstruction, is going to stand the test of time, or can you see this changing as we learn more?
Yeah, so thank you, Mark, for the question. I think there's a huge difference between the EGJ outflow obstruction and achalasia. Achalasia is a very well-defined disease with a known natural history, a lot of effective treatments, and there's abundance of literature around disease pathophysiology, diagnosis, and treatment. For EGJ outflow obstruction, this is just, well, it's beginning to become a bit more clear, but I think we will learn much more in the next couple of years. I think for the moment, Chicago 4 has been an improvement, particularly for the EGJ outflow obstruction, because we diagnosed, between brackets, diagnosed way too many EGJ outflow obstructions. And that led to considerations of basically treatments that were not required, because many of these so-called diagnosed EGJ outflow obstructions were basically artifacts. So I think that will getting better in identifying which EGJ outflow obstruction diagnoses are real diagnoses, they represent a disease, and which ones are artifacts.
Thank you, Ian. So Dustin, can you speak to that as well? I mean, in your experience, what proportion of the outlet obstruction patients is in basically another form of achalasia, which perhaps is less well defined, and what proportion are a whole heterogeneous mix of other things that are causing some kind of structural, probably, obstruction at the bottom of the esophagus?
Yeah, thanks so much for that question, Mark. And that really is the ultimate question in this kind of overall heterogeneous classification of EGJ outflow obstruction, is identifying the group in there that's truly an achalasia variant, and that group exists. Also finding those patients who have other obstructions that are clinically relevant, and certainly weeding out a lot of that artifact that I think in the previous definition was a very large facet of this group. And I think one of the biggest improvements we'll hopefully see in Chicago 4 is that purely artifactual group will be substantially reduced. But to your question, I think that the overall percentage that has the true achalasia variant type of EGJ outflow obstruction truly is a minority. And even in our referral center, where we do see patients that have been some self-selection and previous selection, it still probably is about 10% of patients. And in some centers, it's probably going to be even less than that. That said, it's going to be another portion that will have other mechanical obstructions. And there, I think the most common one that we see is hiatal hernia. And even small hiatal hernias we see can often be either an inducer of pressure in high pressure zones, and also can be at times clinically relevant. So those are things that are important to identify, and at least hiatal hernia can be pretty readily identified on manometry.
That's definitely something that can be recognized, but can you help the people that may well be listening to this? If you look at the pattern, is there something that makes you go, you know what, I think that's a primary motility disorder, and that one over there is more likely to be secondary? What is it that draws your attention, that helps you decide, or do you rely on other tests to make that kind of decision?
Yeah, a combination. And I think that is one of the advances in Chicago 4, is trying to move it along from just the overall EGJ outflow obstruction, but adding in that classifier of the peristaltic pattern, the contractile pattern, because I think that is a primary feature. And when peristalsis is nice and normal and propagating, the probability that is a primary motor disorder is substantially reduced. And we definitely think more about mechanical or artifact in that scenario. But when peristalsis starts to be disordered and disrupted, and we see more spastic features, that is a finding that does push me more into that camp of thinking it probably is, or at least could be, a primary motor disorder.
Thank you. I agree. I mean, the more bizarre it looks, the more likely I feel it's going to be achalasia. Ian, a question from Daniel Siffam, who was hoping to be here, but is probably stuck on a train going to Belgium. You, I think you, your group published recently on deciding between achalasia and pseudoachalasia, or I maybe have a false memory there. But can you speak to that? Obviously, we're all very concerned not to miss a pseudoachalasia, whether that's because of obstruction or indeed some kind of paraneoplastic effect. What do you use to try and be sure that you're ruling out such rare but dangerous diagnoses?
Yeah, I agree. This is extremely important. So on the one hand, you don't want to do additional tests in the form of a CT or endoscopic ultrasound in each patient you diagnose with achalasia. On the other hand, you don't want to miss those patients that actually have a cancer underlying their achalasia, so being a pseudoachalasia. And what we found by comparing a large group of patients that were initially diagnosed and followed up, and then comparing those that eventually did have cancer causing the achalasia and those with idiopathic or primary achalasia, was that the patients with having pseudoachalasia had more often weight loss of more than 10 kilos. Their age was, they were older. They usually had symptoms of less than 12 months before presenting. And often it was reported in the endoscopy report that there was some difficulty passing the EGJ. Now, if patients had 2 out of these 4 risk factors or more, the chance that they'll have malignant pseudoachalasia increases substantially. While if they have just 1 or none of these risk factors, none of the patient had malignant pseudoachalasia. So you're pretty safe in that aspect.
Thank you. That's really helpful. And to both of you, we're obviously living now in the era of peroral endoscopic myotomy. I have a lot of very close friends who are surgeons. I try to be equitable, but who should I be sending to my expert endoscopist to do a myotomy, and who still really would benefit from a classical helemyotomy with a fundoplication, because of course reflux is an issue here. Perhaps Dustin, could you give me your opinion, and if you could finish off on the on that aspect?
Yeah, I think in all comers, having both options to at least propose to patients and to allow them to choose whether the laparoscopic approach is kind of better suited to them with the chance of a reduced risk of reflux after, or the less invasive POEM with potentially needing to take some acid suppression long term, is certainly our approach that we'd like to give patients that power to choose. But I think that when we're really trying to direct patients, some features that we look for, one, if there is the small hiatal hernia, which isn't common in achalasia but can occur, that may be a scenario where the laparoscopic approach to facilitate a hiatal hernia repair may be a little more appealing. I think on the other side, when there is a true spastic achalasia, that with POEM and the ability to actually extend the myotomy up into the esophageal body and ablate the spastic segment of the distal esophagus is another appealing aspect there that definitely helps us direct therapy in that manner. And beyond that, I think, a few other anatomic factors, distal tortuosity for one, may direct maybe more towards a Heller approach, a laparoscopic approach than POEM. But there are some specific features that are surgeon directed based on the technical aspects.
Yes, and if I can add, I agree there that in 90% of the patients, it is basically their choice, their preference, and you can discuss both options. But in the patients that Dusty mentioned, one of the two may be better. Also, we see that patients that had a previous peritonitis in the past or extensive abdominal surgery, they are less suitable for a laparoscopy. And you can preferably do a POEM.
And is there still a role for balloon dilatation?
Oh, yes, certainly. So balloon dilation is effective, particularly if you do multiple. It is relatively safe. It is really quick. And it's an easy procedure to perform. And so, particularly if the patient is a bit older, female, type 2 achalasia, in those cases, a balloon dilation would be an excellent choice. But again, that's in our clinic up to the patient to decide.
Excellent.
Yep.
Okay.
Same approach. Type 2, type 1 achalasia. Yeah, providing that option to patients to choose from as well is our approach.
Yes, and I must say that probably the majority of patients will have the pneumatic dilation as their first choice. If they then have recurrence quickly, they may opt for a more invasive treatment such as Boehm or Hellers.
Well, thank you very much. So I'd like to pass now back to John to address questions to the final group of speakers. John, you're muted.
And I think we obviously touched upon a lot of specific topics that we went through with 4.0, but two of the biggest groups that we really, I think, didn't have a lot of headway in terms of the overall progress were really the hypercontractile and the spastic disorders. And I have Rami and Ying-Lian here who really addressed this in their talk. But I'm going to start with Rami. We don't see spasm that often. In fact, some people don't even really believe it's a separate entity than achalasia. But you definitely see it with the solid swallows. Can you comment on this kind of disparity that we don't really see this disorder quite often when we're doing our 10 supine water swallows, but then, when we invoke a solid meal, we see this spastic pattern. And what do you make of that? Is that really a primary motor disorder or is that a reaction?
Hi, John. Thanks for the question. So you do see a lot of anomalies when you perform tests in a provocative fashion, when you start including solids, single solids or meals. It is important, however, to differentiate between what is clinically relevant and what isn't. And the key here, I think, is symptoms. And symptoms not only that the patient presents with, but also symptoms that are reproduced during the test itself. It's the aim, as you mentioned and as Mark mentioned earlier, is to chase the pathology. And the way you do that is by chasing your symptoms and reproducing exactly what it is that the patient's complaining of. So just like with reflux testing, when you look for a symptom reflux association, we should really be doing the same thing in this context by trying to associate the dysmotility with the symptom. And if I see some anomaly within the swallow mechanism, may it be following water swallows or free drinking or solids, I don't give it as much importance as if the symptoms are reproduced. And I think that is the primary key here.
And just keeping with that, Rami, I think one of the things that was discussed quite often and heavily was the idea that you really needed to have symptoms that were consistent with spasm. And if you saw patients who were presenting with maybe reflux symptoms, that would not be something that would give you more of a conclusive diagnosis. So it fits with that, I think. Don't you agree?
I absolutely, and this applies not just to spasm, but across the board. I mean, earlier we were talking about esophagegastric junction outlet obstruction. It applies there in particular, and Dustin has also mentioned that it's most relevant when you have obstruction associated with a dysmotility associated with symptoms. And we published on this recently, showing that the sensitivity to identifying true clinically relevant OGJ outflow obstruction or any other pathology is by providing provocative testing as opposed to a barium swallow or 5 ml water swallows. It's the most sensitive and specific, and patients responded well following therapy in this cohort when dysmotility was associated with symptoms in the context of EGJ outflow obstruction or what have you. And I think it is, again, the provocative testing is the key, because you're trying to reproduce the real reason the patient is coming there. I often tell patients to bring the thing that contributes to their symptom. If it's a a chicken sandwich, or if it's a pie or what have you, to bring it along and to eat it in front of us.
Preferably not the cheese and onion pie that you guys feed people. But
Well, have you had one?
All right. We'll shift gears here a little bit. So Ying, I know that you've toiled over the years looking at hypercontractile swallows and measuring DCIs and looking at all these thresholds. Do you have any comments on, the Chicago 4.0, how it ended up in terms of these DCI thresholds that we still use? Do you feel that we could have done more, or maybe, leaving it the way it was the right thing? What are your thoughts?
Thank you, Jeff. And concerning the DCI, actually, we are doing a novel analysis. We're using the the pre-P contractile integral and post-P integral, try to find out whether the pre-P distal integral or the post-P contractile integral, which one is more related to the symptom. Actually, according to our finding, we do find that for those patients who have the repetitive contraction pattern, their symptoms seems to be more related to post-P contractile integral. So although we are still using the 8,000 8,000 cutoff value for the DCI, I think in the next step, we should try to look at whether the contractile integral in the post-P duration, maybe they are more related to the symptom. I think this is the next step we can do.
Yeah, I think I agree. I think there definitely needs to be more phenotyping when it comes to that. And going back to spasm, Rami, so what, when we see these patients who have these kind of very weak, early premature contractions, their DCIs are 300. What do you make of those in your clinical practice? Are these things that change after you give them a solid meal, for instance?
Yeah, look, I'm biased here. I've never found anything on water swallows that I didn't either confirm or reaffirm with solids. In fact, it's usually the other way around. With solids, I find something more than with water. If I see something that is unusual with water swallows, then I always look to see what happens when I provide them with a meal. And if the patient has a short distal latency, but not a high contraction, but symptoms are reproduced, then that is more relevant than the numbers. I avoid looking at numbers per se, and I look at patterns and look at the patient's face. And try to make sense of what it is that's happening. But in so doing, you don't have to limit yourself to the normal values of one system. You can extrapolate this to any system, solid state or water perfused, by trying to reproduce what's happening and make sense of it in that context.
Yeah, I totally agree. And I think that's a nice segue to potentially getting some of our other participants on the panel involved. For instance, Prakash, the diagnosis of IEM came roaring back into Chicago 4.0 now as not just a minor motor disorder, and now has actually a place within 4.0. What are your thoughts on that? And then I'll go back to Ying and get her thoughts too.
Thank you, John. IEM has always been a disorder needing a place somewhere. And unfortunately, the way it was characterized prior to high resolution manometry, as well as in the last iteration, left the criteria a little too loose so that the diagnosis was being made quite often and people didn't know what to do with it. It still has issues, but at least now, with the current thresholds, there is some relevance to reflux exposure on the one hand and bolus transit on the other. The problem with IEM as it stands is it doesn't correlate with symptoms. This has been looked at in many different ways. It doesn't correlate very well with dysphagia. And you can't really predict even reflux symptoms, even though it does correlate with high reflux burden, at least using the current threshold. The other area where there was confusion is this whole issue of fragmented swallows, and the proportion of patients that carried this diagnosis was too small for this to exist as a distinct entity. But those breaks in peristaltic content seem to have relevance. And again, that is another problem with IEM because it is a mix of situations where there are long breaks in peristaltic integrity as well as low amplitude or low vigor contractions. So what I feel about IEM as it stands now is that it's a little bit more specific than where it was. But I think there is more to be done with this in the future, maybe incorporating impedance and maybe finding if there are other characteristics that bring this into clinical symptom relevance. So thus far, we've tried to stress that it's still a pattern, can overlap with healthy individuals. And perhaps the only situation where you can say something about IEM is in the context of anti-reflux surgery. If there is significant peristaltic failure, then perhaps it might impact decision-making.
Yeah. And I think, Ying, if you have anything to add, I probably to the point of the multiple rapid swallow and something that Prakash has been an advocate for. Do you use that in your clinical practice?
Yes, actually, in our lab, we usually do the 3 multiple rapid swallow and 1 RDC for every patient. I quite agree with that. We should increase the threshold for the IEM because in the clinical practice, we always have patients who was diagnosed as IEM come to us and seeking the resolution for this motility disorder. And actually in China, we do have some doctors who are very enthusiastic with the prokinetic medicines. Actually, these medicines, they don't work for those patients with IEM. And according to our recent study, we found that the patient who have the IEM with the Chicago classification 4.0, actually the motility disorder is more related to the acid exposure instead of the Chicago classification 3.0, the IEM group. So I quite agree with that. We should increase the threshold. And then for the multiple rapid swallow, for those patients who have IEM, and actually we quite often find those patients, they might have very good response in the multiple rapid swallow. So for those patients who have the normal response in the multiple rapid swallow, we might not we might how to say that for those patients, if you might more confident for those patients to have no treatment at all, because for those patients who have normal response, this patient might be normal instead of they have the real motility disorder.
Great. And I would be remiss if I didn't bring my mentor, Peter Karillas, into the conversation. And appropriately, as we move out of this section on peristalsis, one of the things that I think, again, a criticism of 4.0 is the fact that given this reintroduction of IEM into a motor disorder and making it more restrictive, we have this huge group of patients now that would essentially not have a diagnosis and would be considered normal or borderline. What are your thoughts on that, Peter, that we've expanded this group now to a larger proportion of the studies that we typically see?
Well, just in listening to the other participants here on what the meaning of IEM is, we still don't know. And whether you put it here or you put it there, I don't think makes a whole lot of difference. Its main significance to me is in qualifying somebody for an intervention that might bring it out as a clinically significant disorder. But in of itself, I mean, face it, absent peristalsis is usually asymptomatic. And that's kind of an extreme form of IEM.
Great. Well, I'll pass this back to my partner, Mark Fox, and see if there are any other questions.
Rami's hand up there.
Rami's hands up, but I know he's burning to tell us about solids and IEM. Go for it, Rami.
So, hi, thanks. I mean, the problem with IEM that I find is that I'm not sure what to do with it. When you have a diagnosis of IEM, the layman reads the words ineffective esophageal motility and it scares them. And so they avoid going ahead with further therapy. John and Peter, you produced a very nice paper in Clinical Gastroenterology Hepatology in 2015 showing that minor motor disorders is a good prognostic indicator. And so the finding of IEM is not a bad thing, especially when symptoms aren't being reproduced. What I try to do with IEM is to prove that it isn't there by adding solids and proving peristaltic reserve. What's more important, I think, is the extreme version of IEM, and that's aperistalsis. And in that context, there are two things I need to do. The first is to make sure that there isn't an underlying achalasia that's being missed because of 5 ml water swallows doesn't produce sufficient enough esophageal gastric pressure gradient that's measurable. So you want to stress the esophagus, increase the fluid volume or solids. And the other is to prove that the aperistalsis is actually just because the 5 ml water swallows isn't sufficient to trigger a response and to challenge the esophagus by proving it's normal. And in order so that anti-reflux surgery is not excluded. I mean, from all the studies that we've looked at, looking over the last 5 years, there's very little that defines that using IEM to determine anti-reflux surgery is of any value. Rather, if anything, it either doesn't add anything further or symptoms actually improve and motility improves after anti-reflux surgery in standard IEM. So I'm just concerned about producing a diagnosis that doesn't lead to anything. And so I think that needs to be looked at further, especially in the next iteration.
I think looking ahead, we absolutely have to have outcome studies to show where the threshold lies, where IEM becomes really meaningful. And I think one of the bits of work that I most liked from Chicago in the last few years between Chicago 3 and 4 is your work that brings in the psychological aspects, the anxiety, the visceral sensitivity aspects, and shows how this interacts with the motility disorders to produce the clinical presentation that we see before us. Indeed, quite frequently, the anxiety and visceral sensitivity aspects dominate. And that, I'm sure, is going to be one important part of understanding manometry in clinical practice going forwards. Whereas, on the other hand, we get better and better at identifying these really severe primary motility disorders that respond to specific treatments directed at the underlying cause of disease. But,
yeah, the analogy, by the way, the analogy here that's great is reflux, because if you look at how reflux hypersensitivity changes the diagnosis of reflux disease, the same thing is likely operational with motor deficits. Only perhaps the symptom that's being modulated here is dysphagia. But I don't think we're ever going to hit a numerical threshold that's going to have uniform meaning, because it's always going to be modulated by sensitivity.
Yeah, exactly. Well, one thing that we didn't bring up that is a little bit of a plus of 4.0 is the fact that people don't need to go out and buy new software. You can pretty much diagnose most what you need to do with 4.0 with the current metrics that we have. So one of the nice things about this is that I think, when we evolved from 3.0 to 4.0, there wasn't this added requirement that people needed to do much different, when we were still using these same metrics, albeit they're not perfect and we're using them in different positions and with provocative swallows in different normal ranges. We still have that ability to use this same software, which is definitely a plus. And I think is something that, probably we weren't thinking about when we were putting it together, but afterwards when we finished, we realized that there was not going to be this additional requirement for people. And I'm sure people were very happy about that. Does anyone have any other unexpected positives that came out of Chicago 4.0. I know Peter didn't bring up the EGJ, which is something that was in addition. Anything that you want to talk about here, Peter, with the EGJ, your favorite part of the esophagus?
Hernias matter. I'm not sure we came up with anything else.
Hernia's bad. That's a good message from 4.0.
Well, I think, that is something. So we spent a lot of time with the, contractile interval there and basically got nowhere. We spent a lot of time with the respiratory inversion point and got really nowhere there. But LES-CD separation matters. And interestingly, there wasn't even agreement on that, but I think it was close to agreement on that. And what matters is not, it's the biggest LES-CD separation that you witness. Because as Arian has pointed out, this can be a variable finding. We could not even get people to agree that if it's variable, it's the fact that it occurs that is significant. That was a little bit disappointing.
Yes, it was a tough crowd.
Well, listen,
Any parting words, Mark?
Just to thank all of you for being up early, Yingyan, or being up late. I guess that's myself and Rami and Natalie, of course, and Arjan. It's time for bed here. It's time for Yingyan to get up and start working. It's been absolutely amazing to have the whole world on one screen, and I'm sure that anyone that chooses to listen to this will have picked up some nuggets of information, some insights, some experience that will be helpful to them in their clinical practice. These videos, all of them, will be available for 3 months on the FNM website, and after that will likely be hosted on the NGM Society websites, the UG Education websites, and UGIM Hub as well. And looking further ahead, I hope to invite certainly all of you, but also anyone listening, to Ascona 3, which now is timetabled to happen, COVID willing, from the 1st to the 6th of May, 2022. Thank you very much for being here, and I wish you all a good day, good night, and goodbye.